Dear ladies and gentlemen, dear colleagues, welcome to this lunch symposium sponsored by Medtronic. The topic is on innovation and strategies in TAVI. We'll discuss the design, data, and directions for clinical practice. I made some slides just for the introduction. I do have some conflicts, and these are the objectives for today. We want to discuss the importance of valve platform selection. We are exposed to multiple platform designs. Let's talk now, let's deep dive into the specifics. We also want to understand the latest clinical outcome of supra-annular TAVI versus balloon-expandable TAVI, and there was an important trial that was presented and published not so long ago, and we are very privileged to have the principal investigator among us today. And we'll also illustrate how novel technologies facilitate lifetime management and further improve valve performance and durability. And we're talking about this valve platform. That is where we're going to zoom into. This is the Evolute FX, and we'll also discuss multiple iterations that are currently ongoing and are already available in some of the countries on the planet. But very important part of the discussion today will be the SMART randomized control trial. But rest assured, there's also an interesting live case coming from Leipzig to help us illustrate the point that we want to make in this session. This is the faculty for today. I'm very pleased and honored and so happy to have my good friend Niccolò Piazza. He's also an alumni from the Erasmus University Medical Center to co-chair the session with me. And then we have a star panel with Sabine Bleitziffer, Matti Adam, Dan Blackman, Ole de Bakker, Howie Herman, and then the two operators from Leipzig, Mohamed Abdelwahab and Thilo Noack. There's also Marco Lombardi, who's going to help us in the back to make sure that we are doing what we're supposed to do. And without further ado, I would like to also invite you to ask questions, if you will. You can use microphones. You can also send questions over the app. And with that, I think we can kick off with a first presentation on the SMART randomized controlled trial. I'll invite Howard to, as a principal investigator of the trial, to give his highlights of this trial. Howard.
Thank you very much, Nick. It's a great pleasure to be here and join you at EuroPCR and talk about this trial that was just published in the New England Journal and presented a few weeks ago at the ACC. These are my disclosures. So as many of you know, the SMART trial was a prospective, randomized, controlled, post-market trial conducted at 83 international sites. More than 40% were here in Europe. And it was an all-comer trial with all surgical risk categories, including bicuspid valves, which were present in about 4% of patients. All patients, of course, had symptomatic severe AS and a small aortic annulus defined by a CT annular area of less than or equal to 430 square millimeters. We randomized a total of 716 patients to the Evolute platform versus the SAPIEN platform and had two co-primary endpoints at 1 year with planned 5-year follow-up. So this was the largest, most rigorous trial to date that randomized patients to these two very widely used TAVR devices, and the largest trial to enroll mostly women. 87% of the subjects were women. The main results are shown in the figure to the right, and I'll just review them with you. The SMART trial met both primary and all 5 pre-specified secondary endpoints. Compared to the balloon-expandable platform, the supra-annular self-expanding valve platform had non-inferior clinical outcomes at 1 year, which you see in the upper right, left category, and then superior valve performance. And we utilized multiple definitions of bioprosthetic valve dysfunction, standard hemodynamic measures, effective orifice area, DVI, severe prosthesis patient mismatch, a mean gradient of more than 20 at 1 year. And in all of these measures, we had superior valve performance with the Evolute platform, a 30% lower incidence of BVD, 8 millimeter lower mean gradient, 50% reduction compared to SAPIEN, a 0.5 centimeter squared greater effective orifice area, 0.19 larger Doppler velocity index, and a 7% lower incidence of severe PPM at 1 year. We presented recently at the SKY meeting the hemodynamics over time. They were similar at baseline pre-TAVR, and they favored the self-expanding platform at discharge at 30 days and also at 1 year. We also had less total aortic insufficiency and better quality of life per the KCCQ ordinal outcome at 1 year. And yesterday, we presented the SMART Women subset analysis, which demonstrated consistent results in women, and we previously showed also in patients under and over 80 years of age, similar results that were consistent for both primary endpoints. One of the questions that has come up frequently since the presentation of these results was where we derived the definition for bioprosthetic valve dysfunction. When the trial was designed, the major definition that was in the literature was a combination of VARC2 and 3 European Society definitions published by David Capodanno in the European Heart Journal in 2017. It included structural valve deterioration as defined by echocardiography. It did not require evidence for structural leaflet deterioration, and it required an increase in a gradient of greater than 20 millimeters of mercury. That's where we started with our co-primary endpoint for bioprosthetic valve dysfunction. VARC3 was published just after we began the trial, and it was too late to change the primary endpoint, but we were able to incorporate the VARC3 definition of severe PPM and add aortic valve reintervention. We subsequently also, at the end of the trial, examined 6 different measures of bioprosthetic valve dysfunction. The European one, VARC3's hemodynamic valve dysfunction definition, the SMART endpoint only at 12 months, the National Echo Database from Australia definition for mean gradient, the O'Hare definition from CoreValve and Evolute. Both of those, the O'Hare and Playford ones, are the only ones that have been correlated with long-term outcomes. And then also looked at mean gradient at 12 months. And every one of these measures showed superiority for the self-expanding valve versus the balloon-expanding valve, as shown in the forest plot to the right. So I think the clear evidence from the SMART trial is that bioprosthetic valve dysfunction is superior with the self-expanding platform. How that will translate into clinical outcomes after 1 year is why we're following these patients for 5 years. Thanks.
All right. Maybe before we have a discussion among the panelists, let's move on to some further information on bioprosthetic valve function and structural valve dysfunction. We have a randomized controlled study. There's also registry data. Maybe Dan, you can briefly present some of the registry stuff.
Yeah, thanks, Nicholas. Yeah, I mean, I think that's the question we're all asking, I guess, how we've shown these data, and they're incredibly compelling in terms of hemodynamics, the gradient, the valve area. We have 1.5 centimeters squared versus 2 centimeters squared, and it stands to reason that we'll be better off with 2 centimeters squared, but what we don't know yet is whether this will translate into a difference in long-term outcomes. And I think we're thinking about long-term outcomes in terms of hard clinical endpoints, death, rehospitalization, but also structural valve deterioration and valve durability. And we've got a little bit of data from the UK that can tell us about that. So from the UK TAVI registry, we brought back patients who'd had TAVI prior to 2011 who had echocardiographic follow-up at least 5 years following the procedure. We initially published the data in JACC, and then a follow-up analysis was published in CCI last year. And in this analysis of our long-term follow-up data, what we further did was to divide the incidence of structural valve deterioration according to valve type, but also according to valve size. And these are the data that I'm showing here. So if I can just walk you through these. We had 221 patients who'd had TAVI in that time frame. The median echocardiographic follow-up was 7 years post-procedure. And we looked at the incidence of severe structural valve deterioration according to valve type and size. And during that time frame, there were only 2 sizes of SAPIEN valve, 26 and 29. And there were only, 23 and 26, and there were only 2 sizes of core valve, as it was then, which were 26 and 29. And what we showed was that the incidence of severe structural valve deterioration with a large SAPIEN, a 26, and with small and large core valves, 26 and 29, were equivalent and very low, less than 5% incidence of severe structural valve deterioration. But when we looked at the small SAPIENs, the 23s, the incidence of severe structural valve deterioration was far higher at over 25%, 28.6%. Now, these are hypothesis-generating data. If we look It's small print, so I apologise for that, the number at risk, especially when we get to these later time points. It's very low for the small sapiens, and I think we need more data to explore whether this is the case. But it's also interesting when we look at the kind of Kaplan-Meier curve, when we start to see that separation, around 6 years or more. So certainly some data here to suggest that the difference in hemodynamics with small self-expanding versus balloon-expanded may translate to a difference in valve durability. And there'll be some more data looking at this from a larger European durability study that will be presented, if accepted, at ESC and published around the same time. And then the second point, I guess, which we've discussed after the results of the SMART trial, is how many of our patients does this data apply to? What proportion of patients have an annulus, which is 430 millimetres squared or less? And these are a few registries that address that. And it's interesting, when you ask these people about this, they'd say, well, it's probably 20% maybe. But actually, it's more like 35 to 40%. So in Japan, where we expect anatomy to be small, actually nearly 60% of patients with an annulus measured at less than 23 millimetres or less, and around 35 to 40% in European and North American studies. And certainly when we looked at our own data and leads, we found it was 41% of native valves with an annulus in the SMART trial area. So Nicholas, thanks. A few points for discussion there.
Yep. And then to complete the introduction, we always have the sense that women are underrepresented and that we not have enough data focusing on women. So Sabine, maybe you can give us a brief overview on the status there.
Yes, I would like to give you more insight into female aortic valve stenosis. So female aortic valve stenosis is different. We have to understand this. They are different in terms of clinical presentation, pathophysiology, and anatomy or size. So the clinical presentation of females with an aortic stenosis is really different. Females tend to interpret their symptoms differently. They psychologize their symptoms. They are thinking, oh, I'm a lot under pressure, I have so many things to do, I don't feel well. And male patients tend to somatize their symptoms. So that's a huge difference. And this leads to the fact that females are diagnosed later, so then they present with more severe symptoms at an older age, at a later disease state, and with more comorbidities. And also the pathophysiology of the female aortic stenosis is different. Females have less calcium, less calcified aortic valves, more frequently low flow, low gradient aortic stenosis than male patients, and this leads maybe more often to an underestimation of the severity of their aortic stenosis. And it is intuitive, of course, females are smaller, the anatomy is smaller, the size is smaller, but we are now starting to understand more and more that this needs special recognition and that there are specific challenges of the small anatomies for treatment. And all what I have said leads to the fact that female aortic stenosis is underdiagnosed, undertreated, and females are under-enrolled in clinical trials. Look at the chart on the left. This is the adoption of treatment for the aortic valve treatment in 12 European countries across all age groups. So this is just the numbers of aortic valve treatment per million inhabitants in these 12 European countries. And you can see on the left, the blue, the men have much higher numbers of aortic valve treatment. And this is surprising because we assume female and male aortic stenosis are equally distributed. And if females receive a treatment, they more often receive TAVI. This sounds logical because we have said they present at an older age with more comorbidities and so on. And so how much under-enrolled females are can be seen with the numbers on the right. For example, in the Evolute low-risk trial, that's 34.9% female patients. In the Partner 3 trial, 30.7 patients. And so I think the SMART trial really can fill this gap in the under-enrollment and under-recognition, and especially the female sub-study, so the focus on the female patients in the SMART trial. Demonstrates again that there are differences in the different platforms, especially in these small anatomies, and that there is a benefit in the hemodynamic outcomes for the self-expandable Evolute valve. And how the clinical outcomes will relate to that is, of course, subject of the longer-term investigation. And with this, I would like to conclude and emphasize that patient-tailored medicine is also gender-sensitive medicine.
Absolutely, absolutely so. So we have 4 minutes for a panel discussion. And, well, I have to start with Howard. There is this imbalance between the two primary endpoints in SMART. You have that clinical endpoint, no difference, and then there's this huge difference in the endpoint of bioprosthetic valve function. What is the plan with SMART in terms of follow-up? Because that's going to be very important, right?
Yeah, thanks, Nick. I wouldn't call it an imbalance. I would call it a design. We designed the trial to look at the hemodynamic differences, expecting that there would not be a difference in clinical outcomes at a time frame so early, at 1 year. So the goal of the trial was to examine how important these hemodynamic differences are over time. And we are planning 5-year follow-up, so we will be examining those clinical outcomes as we proceed further. You saw, for instance, even in the women subset analysis presented yesterday and that Sabine just showed, that the difference in the clinical outcomes was actually a little greater in women than it was in men, still non-inferior. And we'll have to see how those curves change over time. But we weren't studying structural valve degeneration. We were studying differences in valve dysfunction, which is the hemodynamic differences. And we want to know how those affect clinical outcomes over time. In the interim, I think the take-home message from a study of those two different endpoints is that you can have equivalent clinical outcomes with better hemodynamics utilizing the self-expanding platform. And so there's no downside to having those better hemodynamics in the short term, and what we want to know is whether they'll translate into hard outcomes in the long term.
Mm-hmm. Mm-hmm. Then in terms of durability, valve durability, you presented the UK data. Just an hour ago in another late-breaking session, Luca Testa was presenting the Italian data with mean follow-ups up to 12 years, but only 10% of the patient population reached to 10 years, because obviously the mean age when they entered the study was 82 years old. So it's very difficult to distract substantial data from those data sets. Is that the same story in the UK, because the patients are older when they enter the study?
Yeah, I mean, I think, it's retrospective registry data. A lot of patients have died. We don't know why they died. They may have died of valve failure. So we have to accept all the weaknesses inherent in that. But I think we've seen patterns, the data from Munich, which was single center data, but a decent number of patients, they showed the same thing. Better durability with self-expanding valves overall. We've had hints at that from the randomized controlled trials. As you know, with Notion, we've seen fantastic long-term durability out to 10 years. So there's a consistency, I think, in the data. So although we accept the weaknesses of registry data, especially retrospective observational data, when we see the same pattern emerging study after study, it starts to perhaps become a real message that there is a difference there. And we're going to get some 10-year data. So TAVI, as you know, extended the follow-up from the originally planned 5 years to 10 years. So we'll have intermediate risk data, patients with 10-year randomized controlled trial outcome. And then, it's interesting with SMART. I must say I was advocating strongly that we should follow them up for 10 years. But now I'm thinking 5 years is going to be plenty to see a difference. But that's just my personal perspective.
What do you think of that, Nicolo? Will 5 years be enough?
I don't think so. I think we already have 5-year data. Even just anecdotal experience would suggest that 5 years is not enough. I think we really need to hit the 10-year mark.
Mm-hmm. I would disagree with that. I think we have good data on severe PPM. We have good data on high gradients that they matter as soon as 5 years. So I don't think we'll have to wait 10 years to see that. And we already saw in the low-risk Evolute trial differences between Evolute and surgery at 4 years. And one could make the argument that part of that difference is the difference in hemodynamics between surgical valves and Evolute valves, which is not that dissimilar from what we saw in terms of the magnitude of difference.
Then I want to hear the opinion of Ole, because he is involved with Notion and he has 10-year data. Yeah. And then there is no difference between surgery and TAVI, but there is an enormous benefit in terms of hemodynamic valve performance with TAVI.
Yeah, I will touch on that in my presentation, to be honest, so maybe I can show it there. But indeed, a 10-year follow-up, this was a core valve platform in the Notion compared to the surgery. If you look to severe structural valve deterioration, which is true deterioration of the valve, because it means it's a mean gradient of more than 30 millimeters mercury and an increase from baseline right after the TAVI of more than 20 millimeters mercury. So I think everybody would agree that this is a real true deterioration of the valve hemodynamics. Well, this was seen in only 1.5% in the core valve arm versus 10% in the surgical arm. So I think this was really fantastic data for the core valve platform, at least. Whether we can immediately translate this to all the TAVI platforms, I don't think so. I mean, to be honest, and that's also showing here, indeed, the hemodynamics. There's big differences between all these different platforms, and that could turn out into real differences in SVD and BVD at 10 years.
Yeah, but then again, does it translate to clinical data? That is, at least in notion, it didn't.
No.
Right.
Well, yeah, it's also, again, we
Smaller.
were lucky, a small sample size, 35% was still alive there. It's not like in most registries that only 10% of population was still alive at 10 years. No, we had 35% still alive. It was not turning into these hard clinical endpoints of death or stroke also, but I mean, I'm also always wondering how important these hemodynamics are for just exercise tolerance, or especially it's not so important if you treat an octogenarian, but if you treat a younger patient, I think these are still active patients sometimes. So how important is it for this? That also has to be investigated.
So as you get ready for your presentation, Nicolo, do we have some questions?
Yeah, sure. So, Howie, two questions, I guess, somewhat related. So, if we do have the answers at 5 years, how does that impact your clinical practice? So, are you going to apply this concept that you implant a self-expanding valve, you have potential better hemodynamics, better longevity? What do you do in your clinical practice? Do you apply it to small annuli only or across the board?
Mostly to small annuli, but I think, it's only one factor that we consider when we're in a heart team discussion. There are other factors that go into the choice of valve, but I think now we have hard endpoints that allow us to make that trade-off more objectively than we have had in the past, and we can use those hemodynamics. I'd also argue that 10 years may be too long because of competing risks for mortality, that there's going to be a bell-shaped curve where you see differences at 5 years, but by 10 years, competing risks for mortality start to even those out. And that's why 10-year data in notion might not be applicable to 5-year outcomes. So it's hard to know at this point.
Right. So are you saying 5 years, 7 years, 8 years, 10 years? It doesn't seem there's a good timeline here.
Yeah, I think we have data at 5 years. I think the hemodynamic differences are greater in the small annulus, so I think we may see differences sooner than 5 years, 3 to 4 years. I think we'll start to see the curve separate more abruptly. Whether that will reach statistical significance at 3 years, 4 years, or 5 years, I can't tell you, but I think we'll start to see differences after about 3 years.
All right, let's talk about lifetime management.
Yeah.
Ole.
Yes, other topic. After this interesting discussion about the small annuli, a glimpse into the future for lifetime management. Yes. So I would say, if you look to TAVI now, TAVI, indeed, we do this since the first TAVI 21 years after Alain Cribier's first TAVI. So we have an experience of 20 years, and in these first 20 years, 2 decades, I would say we have been very focused on optimizing acute outcomes. In the beginning, just procedural success. If the patient came alive out of your lab, you already called it a success. Vascular closure management, we became really good in that too. Reducing PVL, reducing pacemakers with better implantation techniques, etc. Valve hemodynamics, as the topic we discussed. So that's how has been absorbing all our attention. But I think if we talk now about lifetime management and treating younger patients, there are a couple of other topics that pop up as being important. Coronary access, commissural alignment, valve durability, valve thrombosis, redo TAVI. I will, per topic, 1 or 2 slides to introduce you to the topic. So coronary access, is this an issue? Well, it can be an issue. This is the data from Marco Barbanti showing indeed the re-access study that before TAVI on the left-hand side, the 2 bars, you can always selectively cannulate the coronaries. If there is a TAVI implant there in the way, it can jeopardize or it can complicate the coronary accessibility, even mostly for the right coronary artery. So it could be an issue. However, I think many of these issues can be overcome by knowing your prosthesis better and implementing some better or newer techniques. We have to get familiar with other techniques. For example, use of other catheters For example, even sometimes, this is all, for example, for a core valve Evolute platform, I think. So an example, sometimes you don't need your classical Judkins left 4 or EBU. Sometimes it's even a complete other catheter that fits better. You use your J-wire to cross the lowest diamond and get from there into your coronary. Very often, that's what I typically advise, is to do coronary wiring from a distance and then always use an extension catheter. I think that's really the trick that makes it, and that reduces your unsuccessful rate, reduces it by far. So there's a very interesting paper. I don't have the time to go in detail, but I can recommend you this literature. It's great from the Gilbert Tang's group. He described a couple of tips and tricks there. Next, commissural alignment. Very quick, most of you understand what commissural alignment is, I guess. It's that the commissures of the implanted valve, the TAVI valve, are in line with the native commissures. And that's typically also the best for the coronary ostium then. What we want to avoid is the right-hand-sided scenario where we implant these commissural posts right in front of our coronary ostium. That's really not a favorable situation. So I made once this figure where I summed up a couple of potential benefits or disadvantages if you don't succeed in getting commissural alignment. Coronary access, that's a no-brainer, I would say, and there's even data on this. The coronary flow filling, that's just speculation from my side. I let it simulate by FEOPS, for example. They didn't really find differences in coronary filling in their simulations, so it's maybe not true, but that was kind of an idea that in the diastolic filling, the diastolic phase, that maybe the blood flow uses these leaflets as a kind of a skate ramp to fill the coronaries. But that's pure speculation. Central leak, well, there is data that indeed, if you have severe commissural misalignment, that your coaptation is less favorable and that you risk more central leak. That probably has to do also with the dynamics, hemodynamics in the diastole, and that the coronary sinuses, the sinuses, aortic sinuses are used to get the closing and the coaptation of the leaflets. Paravalvular leak, at least that's applicable for sure. We've proven this for other platforms, like an accurate platform. It's not applicable maybe for all other platforms. If you think of redoing TAVI with using leaflet modification, it only makes sense to do leaflet modification if your index TAVI is implanted with commissural alignment. If not, if you have severe commissural misalignment, your leaflet modification is not going to give you any benefit. And then there's a beautiful study from some English group from Southampton where they indeed measure the von Mises stresses, the leaflet stresses, and they prove indeed that if in TAVI valves, if you have these TAVI valves implanted with commissural misalignment, that the stresses are higher on the leaflets than not. So you could speculate this for the durability could be important. And the good news is with the FX platform, this is again from Gilbert Tang's group, very nice data with this FX device. I think we kind of cracked the code to implant this more or less systematically with commissural alignment. So in more than 90% of cases, you can actually implant this valve with commissural alignment. So that's really good news, I would say. Valve durability, that's what we touched upon from the notion. So the 10-year notion, that's the data I gave you here from the structural SVD, structural valve deterioration. Really, really low and very nice data for the core valve platform. Again, I want to emphasize this is with core valve only in the TAVI arm versus 10% in the surgical arm. So really promising data there. And then the question is always, if we talk about durability, I like to show you this slide because it's kind of an eye-opener for some. I think what we really have to aim, if we as an operator or doctor treating our patients, we have to try to think of giving our patients a valve for his lifetime. And what is that lifetime, that expected lifetime from our patients? Well, this is from a Swedish registry. It's very robust, old Swedish national registry. So this is post-surgical aortic valve replacement, I have to say, but this is if you have a high-risk patient, typically these patients, they have less than 6 years of lifespan still in front of them. Intermediate risk patients, these patients 7 to 8, and we do believe that sometimes, well, if we treat a 70-year-old patient, low-risk patients, well, that patient maybe has still 20 or 25 years to go. Well, I think we overestimate this, yes? If you see from these data, even low-risk patients from a mean age of 70, these patients typically have still 12 to 13 years to go, yes? So if you can give them a valve, an index valve, that can help him and treat him and for this time span of 12 to 13 years, you're probably good. Yes, so that's kind of interesting to keep that in mind. Valve thrombosis, I'm almost there. Valve thrombosis is, of course, an interesting phenomenon we saw on CT, and you see the leaflet thickening. It's still hard to say whether this has a true clinical importance, yes or no, or importance for the valve durability. There are some contradicting papers on that in the literature. But what is the good news is, if you don't see it on your valve at all, it's a good thing. Yes, so this is great data from Evolute low risk trial, 4-year data. You see clinical thrombosis and also subclinical thrombosis. It's extremely, extremely low in the Evolute platform. And that's also my experience. I mean, in my clinic, if I see subclinical or clinical thrombosis, I almost can never remember that I ever saw it on a core valve Evolute platform. It's typically on other platforms with more intra-annular leaflet position. So that's, in a way, maybe protective for this phenomenon. And then redo TAVI. I don't have time. We can spend a whole session about this. Just 1 or 2 slides, I think I have about it. But if we do redo TAVI, we have to learn some new vocabulary, like neo skirt length, leaflet overhang. What about the hemodynamics, putting a valve in a valve? Or maybe like Nicolas ever published about a valve in a valve in a valve, how much the opening area actually really reduces. It's dramatic. So we have to learn there really a lot. And that's still a lot of research ongoing there. I think this is the last I want to show you. If we treat these younger patients, the true younger patients, and we have to think of redo TAVI, sometimes what we can do is, for example, this is simulation software from FEOPS that they simulate here. This is a valve in valve, so this is a balloon expandable and an Evolute platform, and then they can simulate and see how much distance will we still have from the valve to the coronary, from the valve to the aorta. So that's kind of envisions you. So you can envision what the coronary accessibility will be or the risk of coronary occlusion if you're treating these younger patients. So that's also really maybe something for the future we have to keep an eye on. So by conclusion, I think you see the first 20 years of TAVI, we had a lot of focus on acute outcomes. Now, lifetime management, I think there's a lot to learn still and a lot of interesting topics to discuss. Thank you.
Thank you very much. So we are 15 minutes from our live case transmission. Matti, why don't you give us a quick overview of the FX technology? How is this technology addressing lifetime management?
Sure, it would be a pleasure. Give me a second. Yeah, so just to phase over to the live case, Nicholas, I thought it's getting now a little bit more practical, and I just wanted to show some of my experiences and some of my case or our cases, how the FX technology is actually helping us and how it actually evolved. So Evolute FX has been approved in 43 countries now, over 65,000 implants, so it's been around now, and it comes in the usual 2 flavors, 23, 26, 29, 34. Delivery size system has not changed much in terms of the outer diameter. The 34 is a 22 French. Now you can still have the Evolute R34 if you are really caring for your vascular diameter. But the system itself has changed quite dramatically. So on the valve size, you see there's enhanced visualizations with these 3 markers. And the whole delivery system has been changed with an optimized stability layer with a single spine shaft and the redesigned capsule and the redesigned tip. So how does this translate into my clinical experience? And if you, for example, see what are these enhanced visualizations? All right, is? Yeah, thank you, Nico. I just tip you and then you'll just, okay, can you help me pronounce it? Okay, great, thank you. So it's all right. So with enhanced visualization, what can we achieve? So first of all, the benefit is that we have height control. On the left-hand side, you see these markers will absolutely help you to be exactly at 3 millimeters. That's the first important thing. The second important thing is you will have perfect control of your alignment because this is a cusp overlap and the FX technology is just the next logical step after implementing cusp overlap implantation, right? So we're using this now to achieve perfect commissural alignment because we can use these markers in a 2 versus 1 fashion to actually see that we are commissurally aligned, okay, in the cusp overlap view. So I'll give you a clinical example of one of our implants. You see we're at 3 millimeters here. There are 2 markers here. I will, maybe it's not good to see from the back, so I just put this little red dots in here. So it's a 2 versus 1 fashion here. And if you go in a 3-cusp view, it's 1, 1, 1. So you know that you must be commissural aligned, okay? And then you can release the valve and have a great result. Additionally, cusp overlap view on the left-hand side will give you control of commissural alignment in valve situations, which is even more important, I think, if we think about lifetime management. But it will also help you deploy in a good depth, right? And it gets even more complex, for example, in TAV and TAV situations, for example, or in situations where you have a lot of structure, a lot of material in the patient, and these markers really help to see where your deployment depth actually is. So I like these 3 markers very much. But what about the system itself? Just briefly touching it because a lot has changed in the system as well. It's really handling now very nicely. The single spine shaft and the redesigned tip will really help you in vascular tracking, especially if you have a Gothic arch like this. The redesigned tip is really helping to get this valve easily over very narrow parts of your vasculature. And is this just Matti telling fairy tales from his cath lab? No, there is data on the Optimized Pro FX register, which is basically Optimized Pro, continued in the FX setting, and you'll see valve performance, discharge, aortic regurgitation, PPM, and commissural alignment numbers are all very good. Just to briefly touch this test, we already have data updates showing that this valve actually performs very nicely. So thank you, Nick. Thank you, guys. Thanks for the help with that visualization.
So thank you, Matti, and kudos to Medtronic for the continued iterations that are meaningful. It's clear that these add-ons of these markers and also the change in the delivery shaft, they really make a difference. But we have to move on because we are progressing to our live case, and per current EuroPCR standards, we will discuss the patient upfront, we will discuss the strategy, we'll do the CT analysis, and only after that, we move to the cath lab. So let's first get started with the patient presentation, and we prepared also some slides here, if we can show them. That's interesting. I have them in front of me. There it is. So we will be seeing a 77-year-old man with a normal body habitus, and he is having progressively he's progressively getting shorter of breath. He has a history of cardiovascular disease, including non-STEMIs and TIAs. You can see his medication. He has some chronic kidney disease. And this was his EKG upon admission. Okay, all alarm bells go off because there is an explanation for his shortness of breath. This total AV block needs to have immediate attention. So they continued with an implant of a permanent pacemaker. And then they also did this echo study after the pacemaker, obviously. And you can appreciate severe aortic valve stenosis, heavy calcification. This is more compatible with a low flow, low gradient aortic stenosis with a depressed LV function, a valve area of 0.8 centimeters square. And here are the coronaries. Luminal irregularities, maybe some distal disease in that posterolateral branch of the right coronary, and then some significant coronary disease in the mid-LAD, maybe the bifurcation may be involved. Well, they were not holding off, so they immediately treated that coronary disease. And based on the ACTIVATE and other trials, you may ask yourself, was that necessary? But we can discuss maybe later. And then we are entering the CT scan. So Nicolo, why don't you discuss step by step the CT? I'm not responsible for that picture, so sorry for that. Sorry.
Okay, so thanks, Nicholas. You know, the first thing you should try to do is look at the valve as if you were a surgeon. So you want to have an endovascular view. That way you're going to get an appreciation sometimes of whether or not there's commissural fusion, the distribution of calcium, and sometimes that might be difficult for some to look on the 2D slice anatomy. So if we look at this anatomy, it's definitely a tricuspid leaflet valve. I would say there's moderate calcification. I think we'd all agree on that. and it's sort of symmetrically distributed. The other way you can look at calcium is looking at a MIP. A MIP stands for a maximal intensity projection, and that sort of highlights, as you see there, the calcium not only in the leaflets, but also you can see some in the left and right coronary artery. So those are the first two things I like to do after getting the aortic valve in plane. So now let's go through a systematic analysis, and what you want to do is analyze the box. You want to analyze the aortic root. And within the aortic root, you're going to have a number of measurements, and somehow you're going to have to understand those numbers with respect to the valve you're going to be implanting. So we're going to start the analysis, and the first thing you want to make sure is that all of your 3 cusps are disappearing at the same time, which I think they are in this case. And then we're going to start making measurements. So we'll start with the aortic annulus to begin with. You don't want to put too many dots because then you run the risk of creating a perimeter error, because you can go in and out, and that might increase your perimeter unnecessarily. The next thing we're going to do is we're going to put a dot on the left coronary cusp nadir. Okay, and this is going to be in red. That's going to help us later on to demonstrate how we get the cusp overlap view. The next cusp we're going to highlight is the right coronary cusp, which is in orange. And the next one we're going to do is the non-coronary cusp, okay, which is in green. The next thing we want to understand is from the annulus, we're going to look at the left main takeoff. Okay, so we're going to go to the left main takeoff, and we're going to put a dot just at the inferior border. And you can see here on the top bottom left picture, okay, on the bottom left picture, you can see that there was an automatic height measurement made in blue. We're going to do the same thing for the right coronary ostium. Okay? And what we'll do afterwards is we'll review some of these measurements together. The next thing we do is look at the sinus of Valsalva, because that's very important for coronary access and also coronary obstruction. Okay? And again, you don't want to put too many dots, but you can put one on the peak, one on the side, and on the commissure. And then we can take also just diameter measurements, and we're going to take 3 diameter measurements, extending to each commissure. And then we're going to go to the sinotubular junction, because the sinotubular junction is also going to be important. And you also need to know the height of the aortic valve annulus to the sinotubular junction, because if you have a very short aortic root, then you might have to consider your implantation depth in some respects. So we're at the sinotubular junction, and now we're going to just get its perimeter as well. And finally, what we're going to do is just understand the height of the left main from the sinotubular junction and the right coronary artery. Okay, so we're done with the analysis, and what you get finally, that box I was telling you about, you can see on, let's go on the fluoroscopic view. You can see now that we've made a number of measurements, okay, and we've understood the geometry of the aortic root. Now, let's look at a few things. One, we can look at the S-curve.
Quick, Nicolo, because
Yes.
we need to move.
So the S-curve here is rather horizontal, so we have a horizontal anatomy. And the last thing we're going to do is look at the sizing. So if we go to the sizing chart, and you can see here in green, we have listed all the potential valve types, but if we go to the Medtronic valve, okay, this is suggesting a 26 millimeter Evolute with 23% oversizing. And just to let you know, the sinuses of Valsalva measured 30, 29, and 32, which are very generous for that valve. So 26 millimeter Evolute.
Beautiful sizing chart, by the way. So let's do a quick heart team discussion. Sabine, we have this 77-year-old male. You've seen the history, you've seen the CT. Are you comfortable sending this patient for surgery, or is TAVI also your go-to? Obviously, the site already treated the coronary, so we know what the site decided, but what is your take on this?
So this absolutely could be a patient that would be intensively discussed. So I didn't really get how his overall risk profile is, but above the age of 75 in general, we feel quite comfortable with interventional treatment.
Yeah. Dan, how is your heart team evolving in this for this particular patient? A lot of discussion, or is this a straight shot?
This would be straightforward for TAVI. I mean, I think we follow the European guidelines, so 75 or over, unless there's a specific reason to favour surgery, complex coronary disease, adverse anatomy for TAVI, then TAVI would be the treatment of choice. And this guy has fairly favourable anatomy for TAVI, symmetrical calcification, as we saw, only moderate calcification, no landing zone calcification. I think the annulus was about 21.1, so certainly
small.
for us, this would be in the small annulus where we'll be using an Evolute platform.
Yeah, and I think from a surgical point of view, would you consider already a root enlargement for this patient if you would end up in surgery?
So now we are going into borderline discussions because, of course, he is 77, and so the higher the risk, the less I would consider the root enlargement also in terms of lifetime management. How important would it be for him to have a large root or large surgical valve?
Yeah. So, okay, that brings us to the strategy for this case. So this patient was discussed by our colleagues in Leipzig. The patient was considered to be biologically somewhat older than 77 years old. He also had some frailty ongoing. So he was at least at intermediate operative risk. Small anatomy. They were quite confident that transfemoral TAVI with a pacemaker up front and PCI was the way to go. So in their strategy, they will perform ultrasound-guided femoral punctures. They use Sentinel embolic protection. They will do pre-dilatation, and then they opted for a 26 millimeter Evolute FX, as Nicolo already suggested by a CT scan. What will become the highlights of this procedure? Mohamed and his team will demonstrate the Evolute FX platform. We learned from Matti what are the new design features that will be definitely illustrated in the case. So without further ado, I think we have our friends already on screen. So Mohamed, if you can hear us, please start with your case.
Yes, hi, I can hear you. I hope you can hear us as well, and you can
Yes.
see us as far as I understood. So thank you for introducing the case, and I just want to show you what we did so far. So just because of limited time we have, we already punctured. Maybe we can show the setting here with the camera. So as you said, because we plan to use cerebral embolic protection because of the fact that this patient has a previous stroke, can be discussed of course, but this would be one of our criteria. We punctured the right radial, which would be our accessory axis in the usual setting. In this case, we have a contralateral arterial and venous puncture. The arterial puncture is 6 French for the pigtail, and the venous puncture is also 6 French. We're not putting a pacemaker here. He has a permanent pacemaker, but we have this wire which we can use for pacing, and it's also a venous access because the patient doesn't have large bore venous access, so no central line. We also punctured here our main axis, the right femoral, as you mentioned, ultrasound guided. I'll show you, if we can show the fluoro for a second. This is the bit tortuous right axis with a catheter inside. But it gets very nicely straightened with a stiff wire, as you can see here, probably because of the lack of calcification. So introducing a 14 French sheath in this case was straightforward. As you can see, this is the Sentinel, which we just placed, and this is where we are. We did an angiogram just to confirm. You can skip this, of course, but we did it to confirm the 3-cusp view. And you can see here the cusp overlap view as well, with very little contrast. And now we're there, we're gonna cross the valve. As you mentioned, we plan to predilate with a small balloon. and then hopefully implant the FX with the intended positioning, as you mentioned, and of course also aiming at good or acceptable commercial alignment because of the different reasons you mentioned, importantly also because of his coronary artery disease. You can see the stents here, so some old stents in the circumflex and the rather fresh stent in the LED.
Moantilo, are you also...
What you also can see here... Yeah.
Moantilo, are you also doing hemodynamic assessment up front?
Yes. Okay. We will do this in a second. We still do it before and after. Because it doesn't cost you a lot of time and it gives you also an idea about what's going on.
So how important is that, Howard, in your opinion, invasive hemodynamics?
I don't think they're very important for
really?
a variety of reasons. One is that I think when you measure them at this time during a procedure, you're often in a low flow state. You're measuring them often suboptimally, not using two pigtails, but even with two pigtails, you're averaging over a distance, the side holes, and that reduces your ability to measure pressure loss recovery. So I don't find them that useful. In my lab, we use transthoracic echo post-procedure to assess the gradient and paravalvular leak, and we don't measure them again. One other question I'd have for Mohammed is, this is a low flow patient. This was a low flow, low gradient patient. And that was before the pacemaker and the LAD intervention. And I'm wondering, number one, has the flow changed? And two, I think this is something we can discuss, the importance of hemodynamics in a low flow patient.
Yeah, two very good questions. So the flow has not changed significantly. And the patient symptomatically improved, of course, after the pacemaker. So he noticed that at least his dizziness and pre-syncopal attacks, they disappeared. But he's still short of breath while doing some moderate exertion. And what's also interesting, not sure whether it's related to the fact that with the reduced EF, remember he didn't get a biventricular pacemaker, but just a dual chamber pacemaker, that his NT-proBNP has increased dramatically from around 2,000 yesterday to 7,000. So there is something still going on with the patient while you're seeing his hemodynamics, which correspond actually to what we've seen on echo, so not a very high gradient. It's around 25 to 30 peak to peak. But going back to your question, so the flow did not markedly improve, and the proBNP actually increased.
So I could end up in a 2-hour dogfight with Howard about this invasive measurement.
But Nicholas, I'm going to team up with Howard. Nicholas, I'm going to team up with Howard. So
I didn't ask you anything yet, so you have to wait now.
It's 2 to 1. It's already 2 to 1. Do we want a panel?
Oh, I can handle you both, no problem. But let's move on with the case. So now, what is your next step? You're going to insert a stiff wire. What is your stiff wire of choice?
It's a Safari. This is a Safari Small, our usual wire. I think we all know how important it is that you place it in the proper position, to take your time to adjust the pigtail catheter, for example, if it's not in a proper location. Because we still, even with the FX, the maneuvering we do with the wire is less, but it has not disappeared completely, to be honest. So we still need to have the wire in a good position in order to obtain a good alignment of the prothesis. Importantly, also before pre-dilating, and this is what we also did offline, after crimping the prothesis, you still need to check it, similar to what we did with the Pro Plus and with the R. And we can see here that it's acceptable with some minor infolding going up to the second node.
You're going to pre-dilate. Matti, is this also something that you would recommend?
Yeah, I was actually preparing of asking the obvious question to Mohammed, was it what his pre-dilatation strategy is, because it's always good to pick people's mind on this, because because it differs from center to center.
Vorbereiten bitte auf 200.
And I mean, in this case, I'm not sure that I would really pre-dil. definitely helps with
When there's
prosthesis
pacing, I'll test
development
it.
and with
Can we
prosthesis
test the pacing, please?
positioning. But I'm in this case, I thought I would have tackled this
140.
case without predil.
And you, Nico,
140.
based on
Yeah.
the calcium that you saw?
I probably wouldn't have pre-dilated. But again, there's, we never know what's right or wrong, but that's our practice with this amount of calcium.
Maximal output. Bitte.
We wouldn't pre-dilate.
Yeah. All right.
So maybe Mohammed,
Und asynchron.
why do you predil? Just do you do it regularly or just in a percentage of cases?
Yeah, it's a good question. I like predilation somehow.
That shows. You show that.
Well, I think that's what we can all agree on, but is it always necessary?
Yeah, it's not always necessary, and I totally agree also with Nico that this calcification is not extreme, and probably we can go without predilatation, but I somehow get a feeling for the valve when I predilate it. Pacing bitte an.
I mean, I think
Yeah,
what we can
pacing
say is we know that pre-dilatation is safer than post-dilatation, and that pre-dilatation
capturing
reduces the
every,
need for
beat.
post-dilatation.
So let's
there is a
do
move
pacing
towards more
180.
pre-dilatation. I mean, this is a borderline case. I think we probably would have pre-dilated, but it is, it's
And
borderline.
your comment is that the pre-dilatation is less aggressive than post-dilatation.
Yeah. And there are some registry data showing that the adverse consequences are less with pre versus post. So, if you're saving some post-dilatation, you're probably increasing your safety.
It's a very good point then.
And obviously super fast. Yeah. And what was the size of the balloon? Because we're talking about a small anatomy.
Yes, it's a small balloon. It's a 20 balloon. Okay. So I'm sure Nico has shown the CT measurement. So the minor axis was around 19-20 max. So it's a small balloon. It's not an aggressive predilatation, and you don't need to aggressively predilate in this anatomy. But it's some sort of some preparation of your landing zone. But I agree, it's something that probably you don't have to do.
You also introduced the Sentinel Filter. Also for Dan, you are still involved in the UK randomized controlled study. What is the status of that trial?
Yeah, so
Heads up.
So the trial originally was 7,700 patients, so it's powered to reduce the risk of stroke from the incidence of stroke from 3% to 2%. So there's been an interim analysis after just over 5,500 patients, which recommended an extension to over 9,000 patients. So what we suspect, although it's speculation, I haven't seen the data, is maybe the overall stroke rate is less than the 2.5% that was predicted for the overall population. But equally, we believe that there must be a difference based on that, and otherwise we would have been asked to stop the study after 5,500 patients. So currently, it's about 6,700 patients have been recruited. So
But targeting more than 9,000 now.
more than 9,000 now. And so there's also, as you know, probably, there's a pre-specified meta-analysis with protected TAVI as well. So we're ultimately, with protected TAVI, going to have maybe 13,000 plus patients. So we should get a definitive answer.
Absolutely. Okay, Mohammed, show us the FX.
Yes, so it tracked very nicely. So we, as usual, 3 o'clock position of the flush port for increasing your chances of commissural alignment. It tracked very nicely. I didn't even have to look at the vessels while advancing it. And now we are in an LAO view. So we'll zoom down a little bit, and you can see here what we also know from the Pro Plus. I'll take a cine, and you see here that the hat marker, what we look at in an LAO projection like that, is that it's looking at the outer curve, and it is. You can also see the tiny markers, which is actually something I don't look at in this view, because I really don't know yet how to interpret the position of these markers in the descending aorta. But you can see, you can identify the 3 of them.
But the head
And
marker
then
is
we
the
zoom out
important
again.
thing that you look for now,
Yes.
right? That needs to be at
Yes,
the outer
exactly.
curve, right? Yeah.
Yes. And now we'll move through the arch, and let's see whether the marker remains at the outer curve, which it does, correct? So let's do a cine again. Tito, can you push the wire a little bit, please? Thank you. Okay, so now it's here at the outer curve. So this is what we look at now while crossing the arch when it comes to commissural alignment. I'll reposition my pigtail a little bit. Seems that it's I need a wire, please.
And what's going to be your
Because of the
projection
tortuous
for the
axis,
implant? You start in a coplanar, you start in a cusp overlap. Briefly, walk us through.
Yeah. Yeah, I'll actually go to the cusp overlap probably now right away. And then I will change at a certain time point to go to LAO caudal again. It's not necessarily the 3-cusp view, but it's a view where you will be able to check your implantation depth, not only on the non-coronary side, which you can do nicely in the cusp overlap, but on the left coronary side as well.
There's one interesting difference we can already see, Nicholas, from FX, which is the valve is going around the outer curve of the aorta. And with Pro Plus, with the 2 spines, generally it was held to the inner curve, which made it harder to get coaxial. So this is a nice demonstration of that change with FX.
So let's move to the...
So this delivery catheter, it's more than just the bright green color. There's more to it. Got it.
It's the bright green color of Mohammed's cath lab that's troubling me.
Okay, so let's push a little bit on the wire. I will now move closer to the valve. The problem sometimes with the cusp overlap is that you see this overlap between the ascending and descending aorta, which makes the assessment a bit tricky, but we can try and modify a bit and get this out. So this would be the exact cusp overlap calculated. Let's do a cine here and have a look at the orientation.
Mohammed, what's
Can
the
we
actual
zoom on
view?
that, Thilo, again?
Mohammed, what's the actual view you're using?
Yeah. The view currently I'm using, it's RAO 26, caudal 16. So, the cusp overlap, I think, was 30 RAO and 19 or something like that. I'm not sure what you calculated, Nico.
Yeah, it was about RAO 35, caudal 20.
Yes. So again, we will. Thilo, can you zoom in on that as you just did? Oh, sorry.
I think one thing that we have to realize is that the whole point of the cusp overlap is to get that delivery catheter in plane. You have the annulus in plane, but if your cusp overlap works if that delivery catheter's ring goes into plane as you cross the aortic valve. That's the goal, to get both the annulus and delivery catheter both in plane.
And it looks actually nicely in plane here, Nico, you agree?
Yeah.
Yeah. But in addition, what I'm looking at here are these tiny dots and also the hat marker. So if you look here, you can see that the hat marker, we know it's in the front because it was on the outer curve in LAO, and now it's looking central, so it's center front. This gives you also an idea that probably you are commissurally aligned. And if you look at the tiny dots, I would see, despite the fact that they are very tiny, that we can see one of them on the right-hand side, in the commissure between right and left, and 2 on the left-hand side, which would be what we actually need. So there's no need to change anything here now, and we'll move on with the implantation. What I'm aiming at is not like a very high implantation. So if I can get this valve at 4, 5, maybe even 6 millimeter, I will be more than happy because of the factors that you mentioned. Regarding access, it's not only alignment, it's also valve depth and also the redo possibilities. So let's start here, Thilo. Pacen vorbereiten bitte auf 140.
So as you are unsheathing, obviously you expect the frame to drop down just a little bit, and then you will start to rely on these markers to help you understand the 3 millimeter depth.
Yes. Noch ein Flugo. Okay, let's stop here for a second. Angioshes. Okay. It's fine. Maybe I can get it a bit higher, but not too high. Okay. We're pacing at 140 just to have some stability. Weiter pacen.
Yeah, so importantly, you need 2 markers on the left side of the
Stop
screen,
pacing.
1 marker on the right side of the screen, and a cusp overlap
Stop
view.
pacing.
If you would go to a coplanar view, you would see 1 in each cusp, 1 marker in each cusp.
Unconscious.
So there are several variations to this implant, but I think an integrated approach with multiple projections is really key. It has become key to really appreciate first commissural alignment, but also your implant depth.
You can also see
what
that
do you guys think of this height?
Howard.
I think it looks great, Mohammed, with the one caveat that you're not in a true cusp overlap view, you're in a near cusp overlap view. And if you went a little more caudal, you might be able to superimpose those 2 markers on each other and know exactly what your depth is.
I
now
think
it's
we
too
were
high.
too high.
You kind of had this
Placing
little
between
tulip
the
shape on the non,
Yes.
so it looked a little bit high, and I think it was contributing to the fact that, as you all mentioned, it was not perfectly in plane.
So let's hear what Mohammed is
Yeah.
doing and what he's just to make him concentrate.
Yeah, so it was obviously too high, so the valve answered the question. Remember, the patient does not have a lot of calcium. So we'll try to get this a bit deeper. So we resheathed, as you've seen, patient is stable still. We'll try to get it a bit deeper. And then, of course, when the valve moves like it did without doing anything, then probably we will wait a little bit after the initial implantation phase before final release, just to make sure that the valve is stable.
And there is a lot
So
of push on
pacing
the
again.
wire still, so that also might contribute to
Yes.
to an upward tilt.
I
of the
actually
valve.
released the push
Okay.
before it jumped. Yeah, pacing between.
And to give Mohammed some time, Nico, maybe a question for you. How big was the LVOT? Was there a big difference in LVOT and annular size? Do you remember that?
Similar.
Similar. Okay.
Yeah.
I mean, we always want to individualize our target depth, and this patient's got a pacemaker already.
Yeah.
It was a pacemaker that was put in for complete heart block, so it's probably going to be largely pacing dependent. So that's one benefit of a high implant that's taken out. Not the only benefit, but also he's had PCI, coronary access requirement is likely to be high in this patient, right? So going a little bit deeper also
stop
helps
pace,
with that. So
Yeah.
I'd agree with what Mohammed was saying, that, in this case, let's aim for a 4, 5, 6 instead of our usual 3.
Unconscious. Okay.
now
So
take
as
it
you
to
see,
LAO.
I have removed the wire. It's a bit deeper now.
Yeah.
It still looks, as Matti mentioned, a bit funny on the non-coronary side.
But already no PVL, so I mean, that depth is going to give a good functional result.
I'm pushing a little bit on it and see what's happening.
So this is a LAO view now, or?
Unconscious? Yes.
Yeah.
So we're now in.
Oh, that's
It's
6.
actually not very LAO. It's 0.
This is the
like
coplanar
PE.
view. This is a coplanar
Coded.
view almost.
Yeah.
Yeah.
Almost like the coplanar view is a bit more cranial, so this is a bit more caudal. Probably we have commissural alignment, unusuous, because it's a 1-1-1 configuration here. We are around, I would say, 5 millimeter depth.
Yes, it is. And
What do you think, guys?
In the cusp
Like it.
overlap view, you had the 2 dots on the left side of the screen. Now you have
Yes.
1 in each cusp. This is, I think, commissurally aligned. And in terms of depth, this is a nice depth of implantation. 5, maybe 6.
I agree. I think it looks good, Mohammed. And you're in the middle of the aorta. You can see that in the LAO projection that you're in now, or LAO-ish. So you're not expecting a lot of change when you release the valve in the relative depth on the non and the left. It's about the same depth on the non and the left.
And a nice ceiling, so there is no AR visible here already. You have a high diastolic aortic pressure. There's no point in doing echo. You just need to do invasive gradients. Kidding.
And I
You know
think
what?
this- I think this
one of
demonstrates
the aspects of FX that Matty didn't highlight as much, but I think is important, is that when you release the FX, it doesn't jump. the way Evolute R does and CoreValve did, because it's less stiff with the single spine. And I think that's been very reassuring, particularly to my younger operators who were always spooked by that jump at the end when they released it.
Yeah,
Okay.
Howie, I agree with you.
So,
You can see how the delivery catheter is centralized in the aortic root, whereas if we were in the older generations, it'd be probably a little bit more to the outer curvature.
I'd probably push this just a little bit more to the outer curvature before release,
Yeah,
just to
me too.
improve
Yeah.
that. But
Schuss.
Well, it didn't move, huh? Maybe a little.
Forward push and slow release.
Yeah.
That's what I would do.
with basing.
Okay, so let's release it and hope it doesn't jump.
Do you pace when you release, Mohammed?
Yes, I will. So this is why I need some wire. Pacing mal bitte auf 160 an.
Yeah, I was just preparing to ask a question. I mean, in this case, it might actually be cool to
Pacing on.
increase pacing rate and to almost do a rapid
Ganz langsam.
pacing. So you have a slow controlled release. At least I think it's. You don't agree, Niklas?
There are several flavors to this. I think the moment you have contact with your wire again, you can induce again an upward push. So my take is pull a little bit more on the wire and do a very, very slow release. Now that's what they're doing. They're very, very slowly releasing the valve, and then it will be okay. I never do that final step under pacing because I don't want to have wire interaction with the ventricle. But this is a
pacing.
flavor.
Yeah, but I mean that's true for if you use over the wire pacing. You know,
That's what he's doing.
Yeah, exactly, absolutely. I mean, but in case you would not use over the wire pacing, I mean, but then rapid pacing could be an option because you're not interfering with the wire so much. But yeah,
I'm happy with that.
yeah.
Looks good. Look at that.
Very controlled release.
Okay. We'll remove the delivery catheter now. If you noticed, I went back to the cusp overlap or near cusp overlap view now, just to make sure how we look. Ein bisschen push off, no? How we look depth-wise on the non-coronary side, of course. We can just do a cine here. It looks as it didn't move a lot. I think we're still like around 5-6. And look at the alignment here, which looks also very promising. So we used in the past to look at the C pedal on the right-hand side of the image. It is on the right-hand side of the image, but now we have also the dots. So we have markers on each, or like opposite to each commissure. So we have one on the right, two on the left. I think this valve is aligned.
Yeah,
Yeah.
Very nice.
we agree.
Okay.
Obviously, be
So,
careful when you take out that pigtail.
Yes,
That's
I will be very careful.
another hurdle.
Who would have taken the pigtail out before releasing the valve completely?
Draht, bitte.
I wouldn't. I would leave it there.
Yeah?
Yeah.
I always leave it.
So you have 50-50 on the panel. So
I usually even take it without a wire, but in his case, I noticed because of the tortuosity
Yeah.
that it was not
Yeah.
that easy to control this.
I think it also depends on how much you're oversized. So in a small annulus and an
Yes.
oversized valve,
Yes.
you want to be a little more careful
So
removing
now
it.
I took it
Yeah.
out. And now, Howie, please allow me to do invasive measurements.
I
No,
can-
you
I-
have to, Mohammed. You have
don't-
to.
you don't
You're not
really-
leaving the room without the invasive
You
assessment.
don't need to, because I can
Okay.
tell you that you'll have a 0 gradient by pigtails and a gradient of 4
You
on
really
echo.
need to. You really
It'll
need
be
to.
exactly
because you
four.
know
I
the
agree with
final
Howard. I
gradient.
Well, I'm going to present the centre ground here. But I think, we need to think when we're measuring the hemodynamics about why we're measuring it, and there are different reasons. And there's one thing that I think unequivocally it does help with, and that's the assessment of paravalvular leak. If you do have AR, and you
Very
can
good
compare
point.
the diastolic hemodynamics before and
Yeah,
after the
also
procedure.
like-
But you're only going
Seeing
to have
the
that if
LVEDP.
the AR is pretty significant. In trace and mild, you're not really going to see that on the hemodynamics, which is why I like transthoracic echo, because I think you get a better assessment of the paravalvular leak. Than you
But
do.
there's an enormous difference in PVL assessment with an echo by transthoracic echo in a supine position and in a left lateral position. You also know that.
Yeah.
So your accuracy of your transthoracic echo in that regard is suboptimal also. So there are trade-offs there. And listen, I don't think we need to be dogmatic, but you need to be very comfortable in what you're doing, and you need to be an expert in the interpretation of what you're doing. And
I think your key point is that you have to know why you're doing it. What is it you're trying to figure out?
Exactly.
Is it the PVL? Is it that you have a residual gradient?
And for AR
And I mean, if
quantification-
there's one setting where I definitely would want to do invasive hemodynamics, it's in valve patients. Because I
Yeah,
think
I think
we
that's
base
reasonable.
also our decision making on the invasive gradients when we're treating particularly small degenerated valves.
But I also take, I think what Howie is saying, at least what I take from it is that the hemodynamics on the
So-
table are not the hemodynamics in 30 days. So, we went through a
Not
period in
even
our
on
centre
day one.
of not doing that 30-day echo because we did one on the table at the end of the procedure. But I think you do need to do a baseline echo that's distant from the procedure to understand what the genuine baseline hemodynamics of the valve are.
And I think it's important to realize that there are two things going into that hemodynamic assessment the next day by echo. One is the flow state that has changed because of pacing, because of anesthesia, because of NPO status. But there's also a change in the valves. There is recoil of both valves, and the aortic DVI changes along with the LV-VTI. So it's not a flow phenomenon, and it changes more for SAPIEN than it does for Evolute. But you do have some recoil of both valves, whether it's the leaflets or the cage, by the next day.
Okay. Well, more data to come. More data to come. But this is a very nice result, eh?
Beautiful.
I think
Perfect.
the implant
Perfect.
depth is spot on. I think you can appreciate the commissural alignment. There's no leakage. Good stuff.
And no gradient.
And no gradient.
Yeah.
Mohamed, any
Patient
comments?
is doing fine, yeah. No, so I agree with all that has been said in this context, except for the invasives. So I'm on you.
I'm with you. I'm with you.
I think it was good that we went a bit deeper in this particular anatomy, and particularly with the fact that when we were a bit on the higher side, the valve had the tendency to move up. Now it remained extremely nicely stable, and what has been published on the FX and what we've also seen is that what I think Nicholas mentioned, that we struggle less with getting this valve aligned on both sides, like to have a similar depth on the non and the left coronary cusp. So it's with the Pro Plus, it was you had to find solutions in order to get the valve coaxial. And in this case, it's a bit easier. Yeah, sometimes you need to maneuver a bit, but sometimes not.
So, Mohamed, before you sign off, we have a question from the audience.
Yes.
Thank you. What are the predictors of left ventricular ruptures with stiff wire? How can we know this ventricle will be ruptured before operation?
Mohamed, did you hear the question?
Yes, I did. So you would like me to answer?
Yes, please.
Okay, so I'm not aware of any studies that have looked at predictors of LV perforation, but out of experience, of course, very old, fragile patients with small ventricles, they tend to have a higher risk. Maybe also because you struggle a bit more with the wire, because at the end of the day, what ruptures is your wire. If it's not in the correct position, particularly after you load the device on it, it becomes like a weapon. So probably very small hypertrophied ventricles in small ladies. The older, of course, the higher the risk. But it's like your manipulation of the stuff of the devices you are using that is could cause rupture or could prevent it. So it's wire position is really a very important step in this procedure and should not be overlooked.
I think, and on top of that, and again, as you mentioned, there is not strong, solid scientific data, but patients who are immunosuppressed, have a lot of immunosuppressive therapy for a long time, they also are vulnerable for LV perforations and also RV perforations, by the way. Okay, I think we're taking out, or you're taking out the Sentinel filter. I think we should move forward. Okay, Mohamed, any final comments from you and the team before you sign off?
Yeah, we will close the groin with one ProGlide and one Angioseal. This is our usual strategy. Otherwise, the patient is doing fine. We're very thankful and grateful that you were hosting us in Paris, and looking forward to see you tomorrow, and enjoy the rest of the day.
Thank you very much to you, Thilo, and the entire team. Thank you. Bye-bye. Sabine, would you have done anything different?
No, I was just wondering now why this valve moved up, because I thought I wouldn't have seen any specific risk for that in this patient.
You mean when there was this pop-up?
I just asked for the size, but the sizing was well in the middle of the 26 valve.
Mm-hmm.
So
well,
interesting. Maybe it was some wire forces.
I think that was it. It was the combination of not the calcium. There was not so impressive amounts of calcium. And then I had the impression that his wire was not pulled back enough, and that there was a little bit too much interaction with the wire and the ventricle. But hey, this is also the beauty of this technology, right? You have repositioning features, and I think
absolutely
well done.
Gives you a lot of preciseness.
Mm-hmm.
Yeah, Nicholas, just a quick question, maybe rapid fire from the audience.
Yeah.
Maybe Maddie, do you consider rapid pacing for release?
Yeah, well, that's what I was during the case trying to get the discussion started a little bit. In a case where where you are high because you want to be high, and so like we're actual complete control of the deployment. In the setting of, we don't use over-the-wire pacing all the time. So if you have a temporary pacer in there, I consider rapid pacing a tool in the toolbox, so you can rapid pace, you have full control of the deployment. There's nothing, flow-wise interrupting. So I think it can be a tool for, a specific amount of implants or, some certain implants, but you definitely don't have to do it all the time. I mean, regularly I deploy onto a fast deployment, fast pacing, yeah.
There's another question.
Yeah.
I want to ask about if this pop-up was repeated, do we have to change the size, for example, or what we can do if it's repeated more than one time?
Okay, so the question is, if it keeps on popping out,
yes,
what would you do?
While implanting it, yes.
Yeah, so would you oversize more? Is that what you're suggesting?
Taking 29, for example, or what we can do.
So, Nicolo, what do you think? You already had 23% oversizing.
Yeah, that's right, Nicholas. Yeah, I wouldn't have gone with a larger size. I think it was just a matter of implant depth. I think getting into a larger valve size, you might watermelon seed, in different directions. And so, so 23% was a good oversizing.
Yeah, I think small tweaks in your and modifications to your implant technique should do the job.
And I think it's very, very important to figure out why you had this movement of the valve, right? And I think in this case we probably were already higher than we thought in the beginning because the cusp overlap was not perfect. We had a parallaxis in there, so probably Mohammed ended up with the first deployment trial very, very high. That's why the valve actually was a bit tulip-shaped. So I think the second implant was just better angulation. Everything was well under control. So
I think nice demonstration of the FX technology. But in the interest of time, there is also an FX Plus technology already.
Sure.
There is some experience in North America. Nicolo, can you give us an overview of that technology?
Yeah. So the Evolute FX Plus rides on the back of the Evolute FX delivery system. So this is a change in the valve and not the delivery system. And so we've seen the evolution of the valves. What Mohammed was using today was the Evolute FX. And what is coming out now, more recently in the United States with the first cases ongoing, is this valve. It's creating windows in the areas where you'd want to get coronary access. And so I'll let the video play, and that will give you an appreciation of the 3 windows that have been created across the valve to improve coronary access. And so although with the previous generation, in the vast, vast majority of patients, coronary access was feasible, now with the introduction of these windows, Medtronic sought to basically eliminate that problem. And so these windows are actually 4 times larger than the original windows. The valve function and leaflet construction is identical. And just to give you a feeling of how big these windows are, you can see that they range from 21 French to 28 French almost, depending on the valve size. And when you look back at the Evolute low-risk clinical trial and you take those CT scans and you try to understand where the average left and right coronary takeoffs are found, you'll notice that these windows, and if you implant at about a 3 to 4 millimeter implant depth, these windows fall within the average coronary heights of the right and left. So I think we have to give kudos to Medtronic for bringing this into clinical practice, and I'm looking forward to using it. I think it's going to make a big influence on our patient management. Thank you.
Okay, with that, we are coming to the end of this session. In the last 90 minutes we discussed innovations in transcatheter platform technology. We discussed strategies. I think we highlighted the importance of the SMART trial. We added some perspectives to it. And I feel that the live case nicely demonstrated the current technology that is available in Europe. With that, I would like to thank all the panelists. I would specifically also want to thank Nicolo for his help and support. And thank you to Medtronic also for their sense of innovation and for supporting this session. Thank you very much for attending and being with us. Enjoy EuroPCR. Bye.